Hello, I'm Jessica Samuels, and welcome to A Way Forward, presented by Beam Credit Union. This podcast takes place on the ancestral, traditional, and unceded lands of the Okanagan Syilx people. Our topic today, involuntary care, and CMHA Kelowna CEO Mike Gawliuk joins me to discuss about what takes place with involuntary care today, the ongoing discussion, and why it can be such a divisive topic. Beam Credit Union is proud to sponsor today's episode. With deep roots in BC and a commitment to your financial journey, Beam believes wellness, mental and financial, starts with support you can count on. Mike, thanks for being here to tackle this tough and somewhat divisive topic. Why don't we start from the top? Let's talk about the definition of involuntary care as it stands right now.
Okay. First of all, to get to involuntary care, we need to talk about the Mental Health Act that exists in BC. And the Mental Health Act is basically the legislation that defines how mental health treatment is to happen. And that includes both involuntary care and voluntary care as it comes to facilities and those pieces. Involuntary care, currently someone can be certified and put into an involuntary care facility based on criterion within the Mental Health Act. And there's 4 key elements of that.
Right. Yeah. What are they?
Well, again, the first is that there is the presence of a mental health disorder. So that has to be there. Now, that could be a diagnosed mental health disorder. The current conversation is around substance use. Now, substance use disorder is a disorder that's identified in the DSM-5, right? Mm-hmm. Along with brain injury. So there has to be, a mental disorder
that's diagnosed or perceived.
Yes.
Okay.
Yeah. That the person is deemed to need psychiatric treatment in a facility is the second factor. And that the person needs care, support, and supervision to protect themselves or others, or to prevent them from deteriorating further. And then finally, that treatment can't be offered voluntarily because the person may not have the capacity to understand or the insight or those pieces.
So 4 criteria, well explained, thank you. For me, I hear those things, and the first thing that is popping in my head is who is deciding this in real time? So it's great to have these on pieces of paper and theory and the diagnosis. We are in real time. And maybe my idea of when and how somebody would be certified is incorrect. If you're encountering an individual that meets those criteria, in the moment, how can all of that be verified? How can you know all of those things?
Well, ultimately, the certification process involves an assessment from either a nurse practitioner or a doctor. They review the information, they may communicate with the individual, and based on their assessment, they can certify the individual for up to 48 hours. So it's that medical professional who ultimately makes the decision or determines whether or not they'll be certified. They need, in order to continue to be certified, within 48 hours, there needs to be another doctor that signs off. And then that would mean they could continue to be certified for a month. That can be extended for another month, could be extended for 3 months after that. And then after that, it could be 6 months, and it can be ultimately ongoing. But ultimately, it's the medical provider who does the assessment and assesses whether or not the individual meets the criteria for being certified under the Mental Health Act.
Okay, so if people in community are encountering an individual like this, and whether it's a pact or circle team or iCart team or whoever is responding in that moment, and they're determined that they, let's say, are danger to themselves or somebody else, what would be happening in that meantime while these professionals are deciding on certification?
Well, I mean, ultimately, if one of those teams were to meet with an individual, you know, they would take the individual to the hospital.
Okay.
Ultimately,
Okay.
is where that assessment is likely to take place.
Mm-hmm.
Yeah.
Mm-hmm. All right. And so what are the checks and balances associated with those assessments? Because it does sound robust, and I'm kind of putting you into a corner here, and you probably know where I'm going, but what are the checks and balances in place? And I think this is important so folks understand that if involuntary care is not showing up in a van with people in white lab coats pulling you from your home, that I'm trying to dispel perhaps an image that some folks might have out there.
Yeah.
Okay, so the checks and balances associated with being certified.
Well, I mean, there are a number of checks and balances in place. I mean, the first is the process around second signature, those pieces. I think there's a few things here that are important to speak to as well that are specific to BC, and I may end up answering your question sort of backwards. What's also important to know is that in BC, we've got the highest number of certifications under the Mental Health Act than any other province in Canada. Recent stats tell us that 20,000 people with 30,000 certifications happen within this province. And what's some of the criteria that's leading to that has been an increased number of people being certified under the Mental Health Act related to substance use. Now, in terms of the checks and balances in place, this is where it also becomes controversial, because there is a section of the Mental Health Act, I believe it's section 31, where there's a term deemed consent. Again, it's we're the only province in Canada to have this. And the deemed consent provision basically assumes that the individual has consented to treatment. How it plays out is when someone is certified, they don't have a say over what treatment they receive. That is decided by their care team, their medical team. They don't have the ability to shape that. Their family doesn't have the ability to shape that. And so it starts to go into the question of human rights.
Mm-hmm. That's the involuntary part?
Involuntary part, is that if you're under involuntary care, you've deemed to give consent to any treatment. You have no say over that, and the treatment team ultimately decides what treatment you'll receive.
See, that's the scary part, I think.
I think certainly it's one of the things that is concerning. Like, again, hearing about certain situations where someone has been certified and have been put on a certain medication which makes them extremely groggy and drowsy, and doesn't allow them to function very well, and even that conversation, it's up to the doctor to make the decision whether there's a med change or anything else, right? So it is scary. The checks and balances that are built into the system are that people do have rights. For those that are involuntarily detained, there is the ability to request a hearing with a review board, and that's made up of a lawyer, a doctor, and a citizen from the community. Now, if you look at those numbers of 20,000
Mm-hmm.
people, I looked up data from 2024, and the number of requests for hearing that came to the review board was around 287. And I believe the number of cases that were heard were around 140. So that's a mechanism that's in place, but it's not being well utilized.
No, we don't know why it's not being well utilized, though.
No, we don't know. There's the reality that as well, when people are, detained, they're to be made aware of their rights under the Mental Health Act. That is one of those. There's also the ability to get a lawyer and to go to court as well. But again, what we know is those mechanisms that are in place aren't necessarily being utilized in a robust way compared to the number of people that are ending up within involuntary care.
Mm-hmm. Let's go back to that 20,000 number every year being detained 30,000 times. Like, what does that number say to you? And that seems really high. And is before we, I don't know, I don't want to judge and say like that's a good or bad number. What does that reflect about what's happening in community? I mean, you certainly talked about substance use, but also, I guess, what's going on, the system, the healthcare system, the resources that we have available.
Yeah, I mean, I think it's likely multifaceted, and I'm not necessarily going to have the correct answer, but what I'm going to suggest is a few things. The world changed dramatically when the drug poisoning crisis started. Like, having been in this field before, being in the field after, that has changed things so dramatically. That's a factor that wasn't there. Again, based on the 20,000, 30,000 piece, what's been identified again is there's increased certification around people who use substances. So I think one of the connections that you can make is the drug crisis that we're currently facing. I think it also speaks to, and this will be part of the conversation, that we don't necessarily have a robust enough voluntary care system, right? And so that means anything from what we talk about, prevention to early intervention, to counseling, to specific care teams that focus on individuals with diagnosed mental illnesses, and up to bed-based care. That there's a lack of those resources within our province. And so as a result, there becomes some reliance on an involuntary approach to care.
Do you think this is because folks are not able to get the treatment early enough that they are then in a situation where involuntary care is required? Or do you think it's because involuntary, it's an either or? The folks who are responding to scenarios and situations that you mentioned have the kind of the single thing that they can rely on to try and get this individual the help they need?
I mean, I would say ultimately, in a scenario where we don't have a robust voluntary care system, people end up getting sick, and they end up getting sicker, and they get to the point where that becomes the choice. In an ideal scenario, you have those services so that you get to people sooner, you help in terms of their health, and the rest of it, and it doesn't have to go down that road ultimately. As far as increased use of that as a tool, I'm not a practitioner, so I'm not just going to say that this is the only tool that is being used. I would say again, it's more a reflection of not having a full system of voluntary services available.
Right.
Yeah.
We started this conversation of what involuntary care looks like today. And thank you, gave a really kind of in-depth background and kind of a state of what we're facing. What's interesting to me as this topic, which in the not so distant past really had such a negative connotation to it. And that is no longer the case. In fact, this is, in recent months, we have service providers and we have political entities calling for an increase in the involuntary care system. There's some very specific caveats associated with this. So let me ask you do you think this is in response to, you said the drug crisis and the drug poisoning crisis? Like, what has perpetuated now the state where we are, where involuntary care is being proposed and actually pushed in our province?
Yeah, I mean, certainly in part, and so this isn't just in British Columbia. Like, right. Alberta's moving quickly in that direction. I think it goes hand in hand with the fact that there's been an increase in the number of people who are unhoused. That has a role to play. You visibly see people struggling. And I think in some cases, where compassion and compassionate people have become tired. We talked earlier before we started around business owners, and I get it. If you're a downtown business owner and you've had your place broken into, or your vehicle's been broken into, or you had someone on your doorstep and they're really struggling, compassion has sort of shifted, and there's a level of exhaustion and fatigue, and I think people are looking for the answer. They're looking for the solution to, again, a very complex problem. I think it's interesting how it's been described, because some people say involuntary care, some are saying compassionate mandated care. At the end of the day, I think they're both the same thing. I would hope that any individual that enters the system and receives mandated care is treated with compassion. I would also want to see that system is set up in such a way that evidence-based services that we know are effective and have impact are part of the package. For example, when it comes to substance use, the gold standard treatment at this point for opioids happens to be opioid agonists, so methadone, Suboxone, those kinds of things. People talk about just go to detox, and get better. In the case of opioids, what is known and understood is that if you come off of opioids and you don't replace it with one of those other options, you have a 98% chance of relapsing. And when you go from where you are, what you've done is you've taken your drug tolerance when you went in was here, your drug tolerance has now come down to here. And if we know that you have a 98% chance of using drugs, you're loading the gun, right? Now, I have faith that evidence-based treatments, like what I just described, will be part of a mandated, compassionate care process. But it certainly begs some questions. I think the other piece is we hear about people with mental health issues, people with substance use issues, and people with brain injury. And so I think there needs to be a level of precision in regards to who it is that qualifies for this level of care. And we're hearing announcements, and certainly we're seeing the advocacy that's coming around these. Well, it was announced by our premier, 50 units in Prince George and 50 units in Surrey are getting added, and there's more to come, right? So I would suggest that what we've seen in our communities as far as a burgeoning population of unhoused people, combined with some fairly high profile incidents, like physical attacks. There was that incident in Vancouver during that festival where tragically 8 people were killed. They got run over by somebody. I think the seriousness of those kinds of scenarios also demands some level of intervention, and is also a driving force behind this kind of approach and legislation. And then ultimately, all communities in British Columbia, big and small, are grappling with this issue of public safety, right? And so this as well becomes, in theory, an approach that could impact public safety in communities, right?
What's the track record for this approach as it stands now to actually work or success? Or I don't know the language to describe it, but it's that folks stabilize their lives and enter into recovery, whether we're talking about substance use or mental health issues.
Well, what I would say first is the question of how do we know it works?
Yeah.
Is an interesting question, because in terms of when the person is in an involuntary setting, if they're safe, they're recovering, then for that time that they're in that system, that works. The research, and certainly in taking a look at things, there has been research that's been done, and there's challenges with the research in terms of methodology and other things, but the research has indicated that ultimately an involuntary approach has had either sort of no effect or a negative effect. In that case, it becomes an issue where, again, what works, what happens afterwards. And I think the research, good research hasn't been done in terms of comparing those in the involuntary system and those in the voluntary system and those that get no help at all to assess what that looks like. But ultimately, the research hasn't demonstrated a whole lot of positive impact down the road. And you hear people talk about their own experiences, and people that have been under involuntary care. Some people will indicate that that's the thing that saved their life. Others will indicate that no, in fact, it created a greater distrust of the healthcare system, and it reduced that person's ability, motivation to present themselves to the healthcare system when they had a need, right? Or I was listening to a mom who struggled with a teen who was using substances. And for the longest time, they really were pushing for voluntary care. And I believe they're from Alberta, and Alberta has specific legislation for youth around substance use. And their daughter ended up detained twice under that legislation. After she was discharged, I think it was within a month, she tragically died of a drug overdose. So what works? I would say what's necessary is there's how you got into involuntary care in the first place. And then there's the key question about what happens when you move on from that resource. So you're maybe stable, you're well, you're on medication, whatever that looks like. There has to be a system there. When you can talk about when people step down from that level of care, what does that look like? Who is the team that's attached to that person? What does the ongoing follow-up care look like for that individual? And I think when that's in place, the chances of people being successful longer term is possible. I think when that's not in place, the reality is it leads to challenges. Discharge from institutional care, like hospitals, youth that age out of foster care, shows that there's a lot of people that when they're discharged from those institutions are discharged back into homelessness and being unhoused. So again, I would hope the goal and the outcome of that is that, and this is why, again, having a voluntary care system is going to be important on the back end of someone who has been either involuntary detained or has received compassionate mandated care in order to maintain a level of wellness. And what I would suggest, and I don't know, I haven't heard, but be really interesting as this model grows within the province, is what kind of evaluation and research is going to be attached to it as well. I think there's an opportunity here to take a look at it and study this approach to create some evidence around, does it work, doesn't it work, the rest of it. And I think ultimately that's important. I don't know where that fits within the plan, but I think it's ultimately necessary.
And also to make sure that we don't have overrepresentation of marginalized groups.
For sure. I think that's, again, one of the concerns, one of the risks ultimately is certainly in the justice system, you see an overrepresentation of Indigenous people. When we're looking at unhoused people and point in time counts that are being done across the province, Indigenous people, again, are overrepresented in those population groups. So I think, we have to also consider the reality that marginalized groups may be further marginalized by this. And that's something that really has to be paid attention to, that we're not replicating, colonial approaches. And so that's definitely a concern.
Okay.
Yeah.
So as we wrap up, Mike, and I feel, as usual, I feel like there's so much that we could talk about more. I just want to ask you then, so do you and CMHA Kelowna, do you feel that there is a place for this model of care, involuntary care, when we talk about the spectrum of care for folks who are struggling? Yeah,
I mean, what I would say is that there is absolutely a place for involuntary care. I'd say we see it as a last resort. Ultimately, when a voluntary care system has been exhausted. But there is no doubt that there are people who are struggling, who are unwell, who require that level of care. Again, as it's been mentioned across the province, it's been identified that it's a very small number of people that require that. So, so in that case, again, as a last resort, that is there's a need for that approach for sure. Again, in advocating, again, to build out that voluntary care system, and the concern that again, we lean into involuntary approaches, and that becomes the solution. I think it's all part of a bigger picture, and it needs to be taken in context of that bigger picture. But yes, if you ask me if there's a place for it, again, as a last resort, there are people that are going to need a level of care that isn't currently available in the voluntary system, that will require an involuntary approach.
All right, Mike, thank you so much.
Thank you.
Big topic, lots to talk about. We will include a lot of these links, including the Mental Health Act, some information about the current status of involuntary care and some of these expansions that are coming out across the province, as well as the Mental Health Review Board, which is the method or the resource that individuals could use if they want to, protest or have a review of their certification. We will include all of that on the Way Forward podcast page at CMHA-Kelowna.org. And if you have any questions about this topic or any of our topics, you can always email me at awayforward@CMHA-Kelowna.org. In the meantime, please do take good care. This episode is supported by Beam Credit Union. With deep roots in BC and a commitment to your financial journey, Beam proudly backs mental health conversations that help build stronger, healthier communities.